Welcome back, clinical problem solvers to VMR. It's Sharmin here. I'm so excited to be joined by the one and only Prof. Raz for the VMR session. And I started recording, and I'm very proud of myself for remembering. How's it going, Prof. Raz?
I am doing well. So excited to be co-discussing with you today and seeing all our lovely friends like Ravi and Yusuf and Julia and the likes.
Yeah, absolutely. It's always a treat. Shout out to Julia for doing teaching points, to Noah and Yusuf for helping with scribing. And uh, one of the CP Solvers greats is going to present a case today. Ravi, it's so good to see you.
I'm not one of the greats. You're one of the greats, Reza, too. So I'm doing well. I don't know. I signed up to present a case. And I'm like, wait a minute. Did I sign up to present to Sharmin? I don't think I've presented a case to you before. So this will be interesting.
Yeah, it's been a long time. It'll be a lot of fun. I can't wait. Yeah, if we can get the board up, team, then we can get started.
Reza, you ready? I'll start with the first aliquot. So this is a 52-year-old male, and he goes to the dentist and he gets a dental cleaning, routine dental cleaning. And he comes back home and he's just bleeding. So he's having excessive gum bleeding after routine dental cleaning. Never had it before. And I'll stop there.
Yeah, thanks so much, Ravi, for both presenting the case and reminding me that I do need my dental cleaning. I did get an email, honestly, about it, so I gotta level up. This is so helpful because whenever we see bleeding, we have to ask the question, is it appropriate or not? And what I mean by that is that if I take a knife and I cut myself, I'm going to bleed. Or if there's trauma, I'm going to bleed. Here, right away, we see the degree of bleeding is out of proportion to the level of trauma. So we know this is pathological bleeding. And whenever you're approaching bleeding, the question becomes, is there an issue with substances within the blood, or is there an issue at the vessel wall? And the easiest way to think about this is a test that we send, like the platelet. So it's going to be really important to get a CBC. If the patient has a platelet count of less than 20,000, then that would be a good way to explain the excessive bleeding because they're having trauma. It's not just spontaneous. There's actually trauma happening. You're going to get a PT, but you can't forget the PTT. These are two different tests that we sent. One is for the intrinsic pathway. The other is for the extrinsic. We actually had a case in Chicago where they never sent the PTT and the patient was just having excessive bleeding after some kind of procedure. And the PTT was eventually set to be greater than 100. And the patient had acquired, I think, factor VIII inhibition. So it's really important to send both of those. But I think the other factor within the blood that's really important for hemostasis, because remember, guys, with the dental cleaning, you should have zero bleeding. And there is trauma. And the reason you're probably having very minimal bleeding is because you have good platelets and you have the ability to block off the bleeding. And I'm trying to go back into physiology here, Sharmin, thinking of like the primary pathway and the secondary hemostatic pathway. But the other factor is von Willebrand factor. And von Willebrand factor, if there is a deficiency or it's not functioning properly, you need that for primary hemostasis with the platelet. So right off the bat, I think a vessel issue is possible if something's infiltrating the vessel, but like applying the base rate, I would want to look at the platelet count, and then I would have a low threshold to send and evaluate for there's like 3 types of von Willebrand deficiency, I believe, 1, 2, and 3. But that's sort of my basic approach. This bleeding is abnormal, is unusual. What's the platelet? What's the clotting cascades doing? PT, PTT. And then having like a low threshold to send for von Willebrand. assuming there's nothing happening extra orally. Sharmin, anything to add before we get more data? This was just like a basic approach.
Beautiful. You can, yeah. I'm glad you took this one because I can never talk about coagulation cascade as well or as beautifully and poetically. So
Dude, if
thanks
they
for that.
fact check that, there's going to be 20% that's wrong. So I welcome people to fact check it.
Yeah, no, I really love that. I think similarly, like thinking about like what's going on within the blood, as you mentioned, with like coagulation cascade, the plasma factor is affecting it, and also I thinking about the blood vessels itself, and I also think about the procedure. Could it be any complications of the procedure that has led to excessive bleeding, which probably seems like excessive, so a complication potentially, or is this patient like learning more about this patient, like any past medical histories, or like are they on any medications that will lead to more excessive bleeding if they were not held, like anticoagulations and stuff like that. So yeah, the host medications, and as you mentioned, then kind of like the bleeding cascades. Excited to hear more, Ravi.
Absolutely wonderful discussion. So keeping it simple, again, a 52-year-old male and more history. There actually isn't any history. He has no past medical history. First time coming to the emergency department, never really going to the physicians for anything. Has never had uncontrolled bleeding before, never had any bruising with any trauma. However, about a week before coming to the emergency room, he did have a fever, which was self-limiting. No night sweats, no weight loss, doesn't take any anticoagulation, no antiplatelets. And I would say I'd probably just stop there with this. The only piece of information is 4-day history of fever. Sorry, 4 days ago he had a self-limiting fever.
Yeah, thanks so much, Ravi. So I think the only thing that is kind of the pertinent positive, as you mentioned, is maybe this history of fever. I don't know what to do with that, especially if it was like self-resolving. If, when we came to the exam, he's like fluorally septic, then you have to kind of invoke like infections plus minus like DAC or anything else that can more make you more prone into a bleeding. But for now, we just make a note of that fever and trended to see if it becomes more important afterwards. And the other thing that is like important in the history is like no prior history of like easy bruising or bleeding. Kind of, especially in the 52-year-olds, we're really invoking more acquired factor rather than like kind of the genetical or something that this patient had for the entire life. Like going to forward, like kind of the things that I would be curious about, it's always like good to ask about like supplements that patient often takes that can make it more prone to bleeding. And the other thing that I would look for any signs of petechiae or anything else that maybe the person has never noticed it or because they thought this is normal for them. So I think like a good exam and also kind of like a history of like meds and supplements would be really informative. Profess, anything else to add?
Nothing. I think that's brilliant of not like anchoring on the fever and just seeing how the data unfolds.
Awesome. So he doesn't take anything over the counter, nothing else in the history. Moving to the exam and vitals. So in the emergency room, he had a temperature 38.1, heart rate was 119, blood pressure 105/57, rest of vital signs normal. Exam pretty much normal, other than gum bleeding. No trauma when looking in the mouth. There was no dental extraction, no cuts or anything that could explain the bleeding. No hepatosplenomegaly, no lymphadenopathy, and I'll stop there.
Okay, I think this is actually really helpful. Sharmin, the one thing we didn't talk about is like, and I don't know how much to invest in this, but I know this is what we're taught. And I think it's pretty true in that, like, when you're having mucosal bleeding, it's more likely to reflect, problems with primary hemostasis, like platelet dysfunction or low platelet number. If you have severe enough of a clotting deficiency, absolutely, you can bleed from the mouth too, but you're more likely to have deeper bleeds like hemarthroses, things that are deeper in the tissue. Now, that's just to guide us. It isn't firm. Like someone with a platelet count of 10 who has knee trauma and bleeding in the joint, totally plausible. But I think since it's just the mucosa, at this juncture, it probably prioritizes an issue with primary hemostasis, be it platelet or von Willebrand's factor. I think the fever, it just confirms that this patient's inflamed. And now all of a sudden, this isn't just atraumatic bleeding, but it's inflammatory atraumatic bleeding. And so at this juncture, it would just be speculation how we can arrive with both inflammation and bleeding. At the end of the day, the bleeding is going to be the platelets, the clotting factors, the vessel integrity, and how inflammation can lead to a dysfunction in that pathway causing bleeding could be through immune dysregulation that can lead to stuff like, now I'm just guessing, secondary ITP, for example. It can lead to factors being consumed, etc. So I don't want to guess too much, but I think all this does for me is to be like, I don't think this is just simple von Willebrand deficiency, and there has to be a link between inflammation and the vulnerability or diathesis to bleed.
Yeah, beautiful. Yeah, that's like such a great pearl for the thrombocytopenia and the gum bleeding. I think of it the same way. And as you mentioned, like not 100%. I think like if I'm like seeing this patient in the ED, probably I'm keeping those two problems separate, like a febrile syndrome and the gum bleeding. And most likely, as you mentioned, in someone like this type of presentation, probably they will come together, but whether like they're different, one is the goal of the other is like to be determined. So I would like keep things broad at this time. And again, like, you know, with fevers, one of the links is infection. So you just kind of want to make sure, like, take a good infection history to make sure that's not how those two things are related to each other. So at this point, you know, the physical exam doesn't really shows us any other like signs of infection, or like I think like he didn't have any hepatosplenomegaly because that is also helpful to know. But kind of like doing, you know, I think the CBC here would be gold, as you mentioned. I like my gestalt is also, I'm like, oh, I'm very curious to see what that platelet shows, or in the setting of someone if it's inflamed, like a pancytopenia wouldn't surprise me either. So I think like which cytopenia, if any, we're dealing with in this case, and also keeping that infectious workup with common things being common, thinking about like, you know, your urinary source, your pulmonary source, your skin and soft tissues. And what we know is that the fever precedes the dental work, I believe. But the other thing is like, you know, this not someone, doesn't seem like someone who's been like in care before. So if they had any like history of valvulopathy in the past, we may have not known, and that in a setting of a dental work could lead to a picture of like endocarditis of some sort. But again, like I think we're just like vaccine politically. In reality, you would get the labs first and see what that CBC and the BMP shows, and then go chasing from there.
Okay, ask and you shall receive. So CBC, the white count's 1.9, hemoglobin is 8, and platelets are 0. What do you think about that?
Okay, let my tachycardia resolve for a hot second, and then I will address this. Oh, wow, this is a very impressive. So, you know, as I was learning like the 1.9, the 8, I'm like, okay. So what I would say, like this patient has pancytopenia with the thrombocytopenia being out of proportionally low. So I think like, that's how I would like frame it. I feel like this is like severe thrombocytopenia within the background of pancytopenia. So I think the most important thing to focus on here is the thrombocytopenia with a platelet of 0. One thing from the manage, you can always like repeat the labs just to 100% make sure it's accurate. And the second is like you also want to make sure if there's any acute complications of it that you have to worry about. And one is like a non-con head CT and someone who's a platelet of 0. You want to make sure they don't have any intracranial hemorrhage hemorrhage. Then the second becomes like, okay, what on earth can make your platelets go to zero? And I think like ITP is the one that notoriously really cause low platelets. However, I think like your no misdiagnoses is always like, making sure you're not dealing with any MAHAs. I'm thinking also about Maha's and also hyper-induced thrombocytopenia, which seems like in this case, he's really haven't gotten any product that would make us think that. So making sure to repeat, get a smear, and get a non-con head CT, and maybe that I'll just stop there and then have pass the mic for Reza's thoughts.
Sharmi, I think once again you predicted you wouldn't be surprised if there was pancytopenia, and here we are. And you know what's interesting too is that I think it would be a mistake for the clinical reasoning to just label this as pancytopenia. I think you have to label it as inflammatory pancytopenia. Like I'm already like ready to link these two together because I think you astutely pointed out that 4 days prior to the dental procedure, the patient was having fevers. So the question isn't just what causes pancytopenia, which there's a lot of different etiologies. And I think breaking it down mechanistically to either the bone marrow not having adequate nutrients, something invading the bone marrow, or something happening outside of the bone marrow, whether it's in the spleen or destruction of all three cell lines, is a good approach. You do have to be cautious because it's easy to see how someone with pancytopenia are more vulnerable to infection. So it could be that they have pancytopenia and then they have an additional hit of an infection causing fever. So that definitely open to that possibility. But I think I'd like to go through that exercise of like what can cause inflammation and pancytopenia. And by the way, for this patient, we would send, of course, a peripheral blood smear. But additionally, I think the immature platelet fraction would be helpful. And I bet you in this patient, it's going to be quite low, the fact that they're actually bleeding, because those immature platelets are actually larger and they're quite functional and they stick pretty well. And I think that's important because if it was a peripheral destructive process, usually you're going to have a high immature platelet fraction and the bone marrow is going to be active. And I don't know this for a fact, but I imagine those patients are less likely to bleed. And they always teach us that like when the platelets are this low, there's very few things that can cause it. And one of them primarily being ITP. Now, this wouldn't be primary ITP because we see that the white count is low and the hemoglobin is low. It would be more secondary. And we know that secondary ITP can happen in the context of malignancy, autoimmune diseases, and various infections. Reflexively, when I saw bleeding and pancytopenia, I started to think about a leukemia, specifically APML. So I think sending the DIC labs is going to be important to see if that's present or not, because that's a subtype of AML. But yeah, I think we're going to send the peripheral smear. We're going to review the medication list very carefully. I know he's on nothing, but make sure there isn't anything over the counter. B12, copper, TSH, HIV, Hep C, and you're basically going through each of those. And of the ones that can cause sort of this sort of inflammatory pancytopenia, assuming it's not a secondary hit from an infection in someone who's vulnerable, you really are using your IMAID mnemonic and saying what infections can lead to pancytopenia, but the platelet count is really, really low. What cancers can lead to pancytopenia? And it's going to be liquid over solid, though that can invade. And then what autoimmune diseases? But the autoimmune diseases through peripheral destruction, and there is no extra. So of all of those, I don't know, like cancer to me sounds like it's leading the DDX, but I think getting the nutritional labs, getting the peripheral smear, getting the viral workup that we all want, evaluating the spleen, like you said. But yeah, I think that low platelet is going to be really, really interesting to see. It's zero. It's very, very low. And that, yeah, so we'll see what happens.
Amazing discussion so far. So, it's interesting when you have a case like this in real time, everything sort of slows down, but this is just happening very fast, and you guys are right on the dot with what's the next test. And you asked for a bunch of tests, so I'm going to give them to you. So, the hemolysis workup was negative. So, all the tests Reza asked for, Sharmin, LDH, haptoglobin, everything was negative. Viral panel, HIV, I think people alluded to in the chat, maybe EBV, CMV, hepatitis was negative. The autoimmune flavor ANA negative, CRP, although was elevated. Peripheral smear, no blasts, no schistocytes, no teardrop cells. I'm going to stop there.
Sharmin, I just spoke for a while, so I'm going to give you the mic to take over here.
Yeah, that was poetry. Prof. Raz loved the discussion. So I think like when I'm like in this situation when most of the workup is becoming like is more negative for me, like in terms of the thrombocytopenia, ITP tends to just rise higher when there's like no other footprint of any other reasons of like the thrombocytopenia. So that's almost like kind of a differential that I would often that I would often invoke in this. Um, I think like the background from like the pantocytopenia, I agree. I think like that aspect of it, I wonder if this is a more of an acute on chronic process, if it's not, as you mentioned, malignancies. I do think like lymphomas, leukemias tend to do this. I'm also kind of struck by his presentation, right? This is a 52-year-old who went to get his teeth cleaned and he was bleeding and came to the ED, right? Like we're not getting any like flavors of like really terrible like B symptoms, maybe some like low grade fevers. I'm just like kind of struck by that dichotomy of like how he entered the emergency room and kind of the degree of abnormalities that we are seeing in this case. So I think like if I was kind of thinking about like kind of blood cultures and like kind of like more like I would think about kind of like TB risk factors. Like I think HIV was already a sense. Kind of like in the autoimmune disease, sounds like with the ANA normal. Like lupus is notorious, but again the age and also the negative ANA rules that out. I feel like lymphomas are tend to be are sneakies, so that is always like remains on my differentials. And then, as you mentioned, kind of drugs, oftentimes, like, has it gotten any recent vaccines or stuff like that, but maybe like something that I would invoke as well. And the other thing is like, oh, does he have something in the background that now is like coming to light again? Like given his 52 years of age, that makes me think that is like a little bit less likely. I think I'm the most worried about ITP in this case. And then I would like kind of think and work up like the secondary causes of ITP. I do think like with a playlist of 0, it's hard, but I do think like at some point getting a bone marrow biopsy in this patient would be really informative. So whatever has happening, I bet there is some clue to it in the bone marrow because of this kind of background cytopenia that already exists. And kind of thinking about, as you were doing still the Prof. Res, is like, what is that like inflammatory pancytopenias and ITP, like what are those overlaps? And I think like malignancy is pretty high, but I'm still like, I'm struck by his like very minimal symptoms coming into the door. So the other things are like, viral tend to like something like parvovirus or something like that can have like profound presentations. But yeah, I'm a little puzzled. What do you think, Prof. Rez?
I think that's poetry. And Sharmin, like I could explain, like let's say someone has ITP, right? And we've all seen this. Like someone comes with a platelet less than 10 and they have anemia, and you're like, okay, their platelet is low, they're bleeding. And so then the anemia is secondary to the thrombocytopenia causing the bleeding, right?
Mm-hmm.
But the thing that argues against that is like the white count is low. Like, how do we explain that with just purely ITP, right?
Mm-hmm.
And the hemoglobin being 8, like assuming that this person was healthy and the prior hemoglobin was 14, there's no way he dropped 6 points of hemoglobin by just bleeding from the gum without coming to clinical attention.
Mhm.
The point I'm making here is that, like, I just want to really, like, if this is ITP, like Sharmin said, it's secondary. It can't be primary because we're seeing other cell lines down. And so I think, like, the question becomes, how can we safely do a bone marrow? Because I think a bone marrow is going to be important in this case, Sharmin. I say that because we really have no other answer. And if we're thinking this is immune mediated, because by definition, ITP is when you have immunoglobulins bind to the platelet. And so how can we decrease antibody production? It's steroids, which usually they get 1 mg per kid. They might give 60 milligrams. Or you give rituximab, which depletes your CD20 cells, your B cells. You don't produce antibodies. Or you do plasma exchange. But before doing any of that, you're going to get the nutritional labs. If we don't have them yet, you're going to get an LDH. And you're going to talk to your hematologist to be like, hey, should I start giving this person 60 milligrams of prednisone? You're going to transfuse platelets and see if they're, and if that will actually be a diagnostic test in itself. Like if it's purely bone marrow as a primary process, then we'll see an improvement. But if it's peripheral destruction, we won't see an improvement. So what I would do in real life, send the nutritional labs, all the stuff that Ravi has mentioned, and then give some platelets and see how the patient responds. They need close neurochecks because they're at risk of spontaneous bleed, and then reach for potentially steroids. But like, gosh, secondary ITP causing this kind of pancytopenia, I'm not yet convinced, to be honest. I'm a little, there's some tension between my illness script and like what Ravi's doing, but Ravi always does this, so I'm not surprised I'm in this space.
Yeah, I agree, and maybe like just calling it ITP is just making us anchor. So maybe we should just say severe thrombocytopenia plus. But I wonder, like, Prof. Rez, if you were taking, I wonder if this is someone who would get pan scanned. I wonder if there's like you should just look for any like lymphadenopathies or like any other traces to kind of help that problem representations like a little bit more. Because I agree, I think like sending the viral etiology, as you mentioned, I think about the bone marrow, but like where else is this disease is at, and it go from there. Because I agree, I think there is like an acute on chronic process going on here.
Yeah, it sets the tension in the. I love you guys are committing to an area or diagnosis, but then you hesitate. So I think I have seen zero platelets with ITP before. So I was right in this space that you're in currently, but there's something that's not adding up. So the nutritional labs, Reza, were normal. Let me give you the bone marrow findings then. So this is where hematology, but I mean, platelets are zero. That's an alarm bell that's being run. You ask for hematology, they ask for a bone marrow biopsy. So yeah, the marrow is hypercellular with trilineage hematopoiesis, maturing myeloid and erythroid precursors. However, no dysplasia, no blast excess. I think somebody was asking about blast. There's grade 1 reticulin fibrosis. There's various grades. This is the lowest grade that you have of fibrosis. The flow cytometry, CD34 positive blast absent. A molecular test, JAK2, MPL, CALR are negative. And I'm going to stop there before the final diagnosis.
Sharmin, jump on your AI as I try to just talk a little bit about this stuff. I think what this is helpful for is like what we can rule out. I think the fact that there is no blast, we can say, hey, that we're not having, AML and a liquid cancer. The fact that it's hypercellular in terms of the marrow, we can say that we're not dealing with aplastic anemia, which itself is a misnomer because it's just not anemia, it's pancytopenia. And I'm sure like there's nothing infiltrating the marrow. And that was also consistent with the peripheral blood smear. So it is true that some cancers you may miss, based on your sample size, you may miss where the cancer is and you have to repeat it. But here it seems like this marrow is trying to respond to the pancytopenia that's occurring. So the fact that there is no actual pathology in the marrow and the marrow is acting appropriately, it really makes me come out of the bone marrow. I don't know if that sounds crazy to you, Sharmin, but I'm like, we have a hypercellular marrow, which is what I would expect it to be in the context of pancytopenia, assuming those cells are normal in morphology and normal in genetic, stuff. And it seems like it is. There's no blasts, and at least the first MPN panel was negative. So assuming those are normal cells, it would push me out of the marrow. And then I would think, okay, what can lead to peripheral destruction of all three cell lines? Lupus, CLL, tick-borne diseases are the ones that sort of predominate that category. So I don't think there's much for lupus, to be honest. This would be a crazy case of lupus. There's no lymphadenopathy, et cetera, et cetera. CLL is an interesting thought. But the white count is low. That's often there's a lymphocytosis. Tick-borne disease, like you wonder, was he anywhere that may have exposed them to tick? And we're getting fooled out because this is like a tick-borne induced pancytopenia. But let me pass the mic to you to see what other thoughts you have as I was just blabbering about stuff I don't know anything about.
I was running the same thing. I'm like, okay, peripheral causes of pancytopenia. And I was like, it would be very fun if it's tick. Yeah, I do think, like, with the platelets, with the bone marrow like that, I'm like, whatever is happening, something is causing an ITP type picture. But I think like that, that pancytopenia still remains. And I'm like, oh, is this person septic? Are we gonna have like a 2 out of 2 blood cultures that comes back positive? That's the other thing I was thinking about, is like if this is like, it has a kind of a sepsis that is like just suppressing, but again, like the reactive bone marrow is like weird. So I was like, yeah, it's a good story for like kind of a tick-borne illness. Yeah, I'm right there with you. I think like probably the platelets, I would venture more in the realm of like ITP. But what is causing that underlying a pancytopenia or the bicytopenia in this case, that I am not sure. I think that I don't know.
I'm smiling because we always find ourselves in this position, Sharmin.
I love it. It means I have more to learn, which I'm reminded.
Oh my God, I don't need to remind me, Sharmin. I already know I have more to learn. I don't need Ravi reminding me.
Oh yeah, Reza, I saw David Wiseman's program give you 2 tough cases yesterday. I definitely was there with you. Those were some crazy cases. So you know what? You guys have done remarkably well. So with this case, ITP and autoimmune phenomena, inflammation, you marry that together, you actually have, if you piece through everything, for ITP, we give steroids, right? Reza, you just mentioned, give some steroids, see what happens. So that was one part of the diagnosis for this case. Give steroids, see what happens. Actually, with the steroids, the whole pancytopenia improved. And then taking off the steroids, the platelets started tanking again. So with cytopenias, and that's why I kind of emphasize that grade 1 myelofibrosis, or that fibrosis that's happening. It's actually a myelofibrosis, but not primary myelofibrosis, which is the more toxic and dangerous kind. So this is what you mentioned, autoimmune, ITP. This is an autoimmune variant of that. And if you look at both, one has clonal proliferation, which is the myelofibrosis. That one's the more dangerous one. And the autoimmune is non-clonal proliferative. So it's like somebody mentioned in the chat, reactive. So it's more like a reactive phenomena. And the prognosis is pretty good with the autoimmune variant. So you guys did mention autoimmune, ITP, and so on. The treatment is the same. Give steroids, see what happens. And that together, plus the negative malignancy workup that all of you had clued up on. So blasts were there. And then all of the markers, the JAK2, MPL, CLER was negative. So we kind of move away from primary myelofibrosis to autoimmune myelofibrosis. And what was kind of interesting with the bone marrow fibrosis with autoimmune is mild, whereas primary myelofibrosis is severe. You don't get blasts with autoimmune, but you can get blasts with primary myelofibrosis. Remember when in med school we learned the TAP? So usually it's dry with primary myelofibrosis. You get teardrop cells and things like that. With autoimmune, you don't get any of that. So also the splenomegaly, you emphasize also, Sharmin, you were mentioning the splenomegaly, but it's absent in autoimmune, but it's there with primary myelofibrosis. And the prognosis with this was pretty good. So the patient's pancytopenia resolved. I had a question that I did kind of look up while we were talking. I'm like, I never thought, why do you have pancytopenia with this? It's, why do you have that? So there's various theories with the autoimmune phenomena that you get with this, but thrombopoietin, erythropoietin can actually downturn, like you get anemia of chronic disease. You can have a downturn in both of those hormones as well. And pretty much it's a diagnosis I've never seen before. I've seen, like you said, Reza, we see ITP a lot, but this case definitely taught me quite a bit.
Oh, wow. I've actually never heard of autoimmune myelofibrosis. I was this years old when I learned about it. Thank you so much. So, can I just make sure, Ravi, I understand it? So the ITP is like, is basically due to the autoimmune myelofibrosis. So the autoimmune myelofibrosis caused the ITP. And that's why like both of them respond to steroids.
Yeah, it's not just targeting the thrombocytes, but it's kind of like that. Usually behind the scenes is some sort of autoimmune phenomena. Lupus is associated, like lupus is associated with autoimmune hemolytic anemia, rheumatoid. So I'm not sure what's fueling the fire here, but it definitely is an autoimmune variant because steroids resulted in improvement in the pancytopenia.
Fascinating. So it wasn't that he had ITP, it was just like all of this you think is the autoimmune myelofibrosis. He just had like a more profound thrombocytopenia.
Right. You could say the next level of ITP, autoimmune fibrosis within the bone marrow.
Wow. But amazing case, Ravi. Thank you so much. I have much to learn. Rez, any thoughts?
I mean, I just want to, first of all, like awesome discussing with you as always, Sharon. I really enjoy it. And like Ravi, you always bring such incredible, instructive cases. And the way that you took just bleeding from the gum to end with autoimmune myelofibrosis was phenomenal. And I think it allowed Sharmin and I to share the knowledge that we knew and to feel the tension despite not knowing the final diagnostic entity. But I'm sure with the AI and with the bone marrow biopsy, we would have been able to put these together and ask that question, is it this? Even though reflexively we wouldn't be able to say it. So it's just like a really exciting time that we're practicing medicine. And it's more so than ever, I think, being able to frame the problem, being able to recognize tension, that matters, because with the AI, it really augments our skills. So I thought this was a terrific case, like such a common complaint, talked on so many bread and butter topics, to end up with a rare diagnosis that I'm not familiar with, Sharmin's not familiar with. But yeah, I think it just had all the elements of a great case. Thank you.
You're the best, Prof. Raz. Ravi, you're a champ. See, that's why you're one of the CP Solvers goats, because of cases like this. We really appreciate you. Thank you so much, Yusa, for ascribing. Really appreciate you jumping in. And Mike to Julia.
Thank you, everyone. Thank you, Ravi, for presenting this case, and thank you, Sharmin and Reza, for discussing it. So the first thing that we should think about in the patient who had a recent bleeding is if this bleeding is appropriate or not, if this degree of bleeding is proportional to trauma. For example, a dental procedure should not have severe bleeding. And some tests are important for this patient who are bleeding, such as CBC. And when the platelets are less than 2,000 indicates as excess of bleeding. And also some important tests are PT, PTT, and von Willebrand factor. Also, we should see if there is any complications from this procedure, and also if this patient is taking any meds that can lead to bleeding. Also, one important thing is if this patient had no history of easy bruising in the past, this is less likely for an inherited bleeding disease. Also, if this patient is having mucosal bleeding, such as in this case, this should be a primary hemostasis dysfunction, like a platelet dysfunction. Also, always with a patient have a fever, always think about infection. And in thrombocytopenia, always think about intracranial hemorrhage. And about the pancytopenia, we should think about some possible causes of this pancytopenia, such as bone marrow, nutritional, and spleen. And think about if this pancytopenia is linked to the fever. Such some infections can lead to pancytopenia, such as parvovirus and TB. And also think about secondary causes of ITP, such as malignancy, lymphomas, leukemia, autoimmune, and low hemoglobin together with low white blood cells count and platelets can indicate that there is a secondary cause of the anemia and less likely from a bleeding. Also, if the bone marrow biopsy reveals that this is hypercellular, this could rule out aplastic anemia and indicates that the bone marrow is responding to this pancytopenia. And the final diagnosis was autoimmune myelofibrosis that has a favorable prognosis, is very rare. And one important thing about this diagnosis is the teardrop cells that is present in myelofibrosis, but not present in autoimmune myelofibrosis. So that's it. Thank you so much.
Oh, brilliant job, Julia. I'm always so impressed with all of you so succinctly being able to uh, teach us all the great learning points. This is such a great case. Thank you so much, everyone. We'll see you next time. Have a good one. Bye.